Hi students, welcome back. So we are going to do fertilization and implantation. So all the events preceding to fertilization we had discussed in gametogenesis, right? Now what we saw at the end of that lecture was, in the video also we saw that the male and the female pronucleus diffuse, and when the male and female pronucleus fuse, that is what is called as fertilization and a zygote would be formed. Now, the female pronucleus, like the secondary oocyte, is still surrounded by zona pellucida, and similarly, the zygote is also surrounded by zona pellucida. What is the function of this zona pellucida in a zygote? See, till the time the sperm hadn't entered it, and till that time we knew, before fertilization, we knew what was the function of zona pellucida, that this zona pellucida will not allow more than one sperm to enter into the oocyte. But now after fertilization, this zona pellucida is being retained. What is its function now? Its function is that the fertilization is happening in the ampulla of the fallopian tube, right? So that implantation doesn't happen there. This zona pellucida will be present. This zona pellucida will not allow the zygote to implant into the fallopian tube, right? Now what is going to happen is that a zygote is formed. This zygote, after 20 to 30 hours, is going to undergo first cleavage, and from a zygote, two-celled stage will be formed, right? And then it's going to further divide. A 4-cell zygote will be formed, and then an 8-cell zygote will be formed, and finally a 16-celled zygote will be formed. Now, from 8 to 16 cell, it is called as morula. So remember, 8-cell zygote to 16-celled zygote is a morula. 8-celled is also a morula, and 16-celled is also called as a morula. Why it is called as a morula? Because morula means mulberry shaped, right? And till now the morula is also surrounded by zona pellucida, right? Now where was fertilization happening? Fertilization was happening in the ampulla of the fallopian tube. Right? Now, this morula or this zygote, it is going to stay in the fallopian tube for 3 days. For 3 days, it will be inside the fallopian tube. Till the time it is inside the fallopian tube, who is going to provide nutrition to it? Nutrition is provided to it by the secretory cells of the fallopian tube. Right? So, in fallopian tube, basically, there are 3 types of cells. Right? Fallopian tube is lined by ciliated columnar epithelium. So, number 1, there will be ciliated cells, right? Ciliated columnar cells. Number 2, there are secretory cells. And number 3, there are PEG cells, right? PEG cells function, we don't know. We don't know what is their function. What is the function of secretory cells? The secretory cells are providing nutrition to the early zygote. And what is the function of these ciliated cells? These ciliated cells, along with the peristalsis, which is happening in the tube, they help to push the zygote towards the uterine cavity. So, zygote moves towards the uterine cavity, number 1, because of the peristalsis in the tube. And that is the main reason for its movement. And number 2, it is because of the ciliary movement. The cilia are pushing the zygote towards the fallopian, pushing the zygote from the fallopian tube towards the uterine cavity, right? Now, here I want you to understand one thing. See, all contraceptives, they prevent any kind of pregnancy. So, they are protective in all kinds of pregnancy. So, if I ask you, do contraceptives protect against ectopic pregnancy? You're going to say, yes, they do protect. But just in case failure of a contraceptive method occurs, then it leads to ectopic pregnancy. And the question which they ask you is that what are the hormonal contraceptives which will lead most commonly to ectopic pregnancy? So if you remember, just now I'm telling you that peristalsis in the tube is the main reason for the movement of the zygote towards uterine cavity. So if this peristalsis is decreased, then the zygote will not move towards the uterine cavity and it will implant in the fallopian tube, and that is what is ectopic pregnancy. And we all know that progesterone is a smooth muscle relaxant. So it is progesterone contraceptives. If their failure occurs, that leads most commonly to ectopic pregnancy, right? Okay, now zygote, after 3 days, it is going to enter into the uterine cavity. And on which day it is going to enter into the uterine cavity? Zygote is going to enter the uterine cavity on day 4 after fertilization. Day 4 after fertilization. Right? And in which stage it is going to enter the uterine cavity? It is going to enter the uterine cavity in the form of a morula. Now, morula, I told you, is 8-celled is also called as morula and 16-celled is also called as morula. So, if I specifically ask you in which cell stage, so it is the 16-celled stage in which it enters the uterine cavity. Clear to all of you? So these are two very, very important questions. When does a zygote enter the uterine cavity? It is 4 days after fertilization. And in which stage? It is in the form of 16-celled stage morula. Right? Now, when I say 4 days after fertilization, I want all of you to understand that in a menstrual cycle, how many days would that count to? Now, in all pregnant patients, there are 3 things which we are going to presume. Number 1, we are going to presume that all pregnant females, their menstrual cycle is a regular menstrual cycle of 28 days, right? And in a 28-day menstrual cycle, we know that ovulation occurs on day 14, right? And in the previous lecture, I told you that the secondary oocyte, the fertilizable span of the secondary oocyte is 12 to 24 hours. That means within 24 hours, the secondary oocyte should get fertilized. Otherwise, it will go waste. In other words, if fertilization is happening, it means it is going to happen on the day when the secondary oocyte was released within 24 hours. Otherwise, that secondary oocyte would have got wasted. So the third thing which we presume always is that the day of ovulation is equal to the day of fertilization. The day of ovulation and the day of fertilization are same in a pregnant female. So these are 3 presumptions which we are going to make. Now when we make these 3 presumptions, so I am going to draw a menstrual cycle based on these 3 presumptions. So first day of the cycle, 28th day of a cycle. Day 14, ovulation has occurred, right? And I am telling you, we presume that the day of ovulation and the day of fertilization are the same, right? So this female who had a 28-day menstrual cycle, on day 14 she ovulated and on day 14 only fertilization happened. So if fertilization has happened, that means now she has conceived, and now on 28th day when she was about to have her period, she is not going to have a period, and this will become her missed period, right? Now I am telling you that zygote is going to enter the uterine cavity 4 days after fertilization. Now 4 days after fertilization means day 18 of the cycle, right? So in your MCQ, either it will be written 4 days after fertilization or it will be written as day 18 of the cycle. Clear to all of you? Right? Okay. Now what happens is that this morula, it enters into the uterine cavity, and on day 5, now the function of zona pellucida is over. Right now, zona pellucida knows that now I have to hatch out. I have to be removed. Unless and until zona pellucida is removed, till that time, this zygote, this morula will not be able to implant. So now on day 5, the zona is shed off, and shedding off of zona is called as zona hatching. Right? So when is zona hatching happening? It is happening on day 5 after fertilization. Right? Now what happens is that as this morula enters into the uterine cavity, fluid will enter into the morula. Right? And anything to which fluid enters, you start calling it as a cyst. So now this morula, because fluid enters into it, you will now call it as a blastocyst. Right? Now, if you see the diagram of a blastocyst, in a blastocyst, you will see a few cells which are attached to one side. The cells which are attached to one side of the blastocyst, they are called as inner cell mass. Right? These cells are called as the inner cell mass. And the cells which are lining the blastocyst, they are called as trophoblast. Right? So what happened? On day 4, morula entered into the uterine cavity. On day 5, zona pellucida was lost. And now fluid has entered into the morula, and now morula is no more called as morula. Now it is called as a blastocyst. Right? Clear to all of you till here? Now this blastocyst has to attach itself to the uterine endometrium. It cannot keep on hanging in the uterine cavity. So it has to attach to the endometrium of the uterus. And this attaching of blastocyst to the endometrium of the uterus, this is what is called as implantation. Have you understood? Now this blastocyst will not keep on hanging there. It will have to attach to the endometrium, and that is what is implantation. And if you, understand implantation in humans, in order to implant itself, this blastocyst will go deep inside the endometrium and then implant. And this type of implantation is called as interstitial implantation. So the blastocyst could have just attached to the endometrium like this. Then also it would have been called implantation, but this is not what happens in humans. In humans, if this is the endometrium, blastocyst will go deep inside the endometrium and then implant. This is what is called as interstitial implantation. So the type of implantation which occurs in human is interstitial implantation. So now, next very important question is, when does implantation begin? Implantation begins 6th day after fertilization. 6th day after fertilization means which day of the menstrual cycle? 14 plus 6, that is 20. So day 20 of the cycle. Now that doesn't mean that implantation happens exactly on 6th day after fertilization. There is an implantation window, and that implantation window is day 20 to day 21. So implantation happens between day 20 to day 21. But if they ask you between day 20 and day 21, which is the best answer? The best answer is that implantation begins on day 20. Right? And implantation is going to begin 10th or 11th day after fertilization. So it is going to end 10th or 11th day after fertilization. Right? What is the type of implantation which is seen in human beings? It is interstitial implantation. And as you saw in the video, the blastocyst is going to go deep inside the endometrium and then implant. After implantation, endometrium will not be called as endometrium. Endometrium will be called as the decidua. So if I ask you what is a decidua, you are going to say decidua is a pregnant endometrium. Right? Okay. Now, what are the phases of implantation? Now, first phase of implantation is apposition. That means now the blastocyst is going to come in contact with the endometrium. This apposition is facilitated by tiny villi-like structures which are present in the endometrium, and they are called as spinopods. Right? What are spinopods? They are villi-like structures which are present in the endometrium. Right? Now these spinopods, they are the morphological marker of endometrial receptivity and implantation. Receptivity and implantation, right? They are the morphological marker of endometrial receptivity and implantation. So number 1 is apposition. Number 2 is addition. Addition is facilitated by proteins like integrin, selectin, right? And the third phase is invasion. Invasion is facilitated by metalloproteinase enzyme. Metalloproteinase enzyme. Now here only you have to remember that blastocyst is invading the endometrium, right? So what is the structure which limits this invasion? What is that structure which is going to tell the blastocyst that no, you have to invade only up till here. You don't have to go into the myometrium, right? That is a layer which is called as Nita-Books layer. Nita-Books layer. Right? And I'll tell you a lot of details about Nita-Books layer when we are going to do placenta. As of now, you just have to remember that there is a Nita-Books layer which limits the penetration of the blastocyst. Right? It is going to tell the blastocyst that please stop. This is till where you have to invade. You don't have to go below that because below that is the myometrium. Clear to all of you? Okay. Then, what is the site of implantation? The site of implantation is the upper posterior wall of the uterus. Upper posterior wall of the uterus, close to the fundus. It is not the fundus of the uterus, right? Now, whenever implantation is happening, implantation is eccentric. What do I mean by that? So, if over here is the uterus and this is the uterine cavity, right? This is endometrium here, right? Now, implantation, and this over here is the blastocyst, and I am telling you that blastocyst will go deep inside the endometrium and then implant. Now, implantation obviously can happen on only one side of the uterus. Implantation cannot happen on both the sides. There is a single blastocyst. So, that single blastocyst will either implant on the left side of the uterus or it will implant on the right side of the uterus. Right? So, that means implantation has to be eccentric on one side of the uterus. Because of this, because implantation is eccentric, that is why in early pregnancy, there is asymmetrical growth of the uterus. Asymmetrical growth of the uterus. Wherever on which side implantation has happened, that side is going to grow more in comparison to the other side. And this is what is called as Piscasek sign. Piscasek sign. The asymmetrical growth of the uterus in early pregnancy, that is what is Piscasek sign. Right? Now, wherever implantation is going to happen, there a gestational sac will be formed. So, if implantation has happened on the left side, gestational sac will be formed on the left side. If implantation has happened on the right side, then the gestational sac will be formed on the right side. In other words, if I ask you that in case of pregnancy, where is a gestational sac formed? You are going to say a gestational sac is also eccentric in location, and this gestational sac is a true gestational sac. We will talk about a pseudo-gestational sac in some times now. Pseudo-gestational sac is not a gestational sac. It is the thickened endometrium which is seen in ectopic pregnancy, right? So, in ectopic pregnancy, the endometrium becomes thick and it starts appearing like a gestational sac. That is called as a pseudo-gestational sac. So, obviously, if the endometrium is becoming thick, and you are confusing the endometrium with a gestational sac, that gestational sac will be centrally located, right? And that gestational sac is not a true gestational sac. That is a pseudo-gestational sac. So, one very important way of distinguishing between true gestational sac and pseudo-gestational sac is that true gestational sac is always eccentric. So, if you haven't understood this just now, you will understand this a little later on when again I'll talk to you about true gestational sac and pseudo-gestational sac. As of now, remember that true gestational sac will always be eccentric. It will either, wherever implantation has happened, there only the gestational sac will be formed, right? Now, there are a few females who have bleeding at the time of implantation, and this is what is called as Hartmann sign or placental sign. right? Now I told you that the blastocyst, it goes deep inside the endometrium and then implants. We saw a video also. So this is something which gives rise to the sign, intradecidual sign, which is seen on ultrasound. On ultrasound, you get a sign early in pregnancy, which is intradecidual sign. And what is the basis of this intradecidual sign? The basis of this intradecidual sign is that the blastocyst is going deep inside the endometrium and then implanting. So on ultrasound, it is visible as intradecidual sign. So this is one of the earliest signs which you get on ultrasound in pregnancy, right? Now, I told you that the endometrium after implantation is no longer called as the endometrium, it is called as the decidua. So once implantation happens, this decidua is divided into 3 parts. So let's have a look at what are those 3 parts. So if this over here is the uterus and this is the uterine cavity, right? This is the endometrium. You all know uterus has 3 layers, the endometrium, myometrium and the serosa. So this yellow colored is the endometrium, right? This pink color is the myometrium, right? And outside is the serosa, right? So this is the myometrium, this is endometrium and this is serosa. Now I am going to let the blastocyst implant, right? So once the blastocyst has implanted, you will not call endometrium as the endometrium, you will call it as the decidua, right? Now this decidua, you can see that it has got 3 parts. Number 1 is that part of the decidua which is lying below the blastocyst, which I have made green in color. This decidua which is lying below the blastocyst, this is called as decidua basalis, right? This decidua basalis is the site for formation of future placenta. So future placenta is going to be formed here, number 1. And number 2, it forms, the decidua basalis forms the maternal side of the placenta. It forms the maternal side of the placenta, right? Then you have number 2 decidua, and this number 2 decidua is the one which is lying above the blastocyst and it is separating it from uterine cavity. So this purple color over here, this decidua, which is like a cap over the blastocyst and it is separating the blastocyst from the uterine cavity. That is what is decidua capsularis, right? So you have a decidua capsularis, right? So how do you recognize decidua capsularis? It separates the blastocyst from the uterine cavity, right? Now, the rest of the surrounding decidua, this rest of the surrounding decidua, which now I have marked orange in color, rest of the decidua. This rest of the decidua is called as decidua parietalis, right? So it is the rest of the decidua. Have you understood that a decidua has got 3 subdivisions, decidua capsularis, decidua basalis and decidua parietalis. Now, in your image-based questions, you may be asked to identify the decidua. And whenever you have to identify the decidua, how you are going to do that? See, whatever image is given to you, the first thing what you have to see is you have to identify the uterine cavity. That's the first aim which you should have. Always the uterine cavity will be marked and given to you, right? Now you are seeing that between the uterine cavity and the blastocyst, we have the decidua capsularis. So whatever decidua is present between the blastocyst and the uterine cavity, you are going to mark it or identify it as decidua capsularis. Immediately opposite to decidua capsularis is your decidua basalis. So just opposite to capsularis is basalis. Right? So now you have recognized capsularis and you have recognized basalis. Apart from this, any other decidua which they mark will be decidua parietalis. I hope that sounds easy to you now. So if that sounds easy, let's see a few examples. Right, so over here, first let me show you all the deciduas again. So this over here is the uterine cavity. This is the blastocyst. This is our blastocyst. And over here, between uterine cavity and blastocyst, the purple color is the decidua capsularis. Right, just opposite to decidua capsularis will be decidua basalis. Right, and any other decidua which they mark will be decidua parietalis. Clear? Now look at this image. This is a transverse section, and again any of the decidua can be marked as X on an image based question and you can be asked to identify it. So the same principle applies here as well. The first thing what you have to identify is the uterine cavity which will be marked and given to you. So over here this white color is the uterine cavity. Right? Over here this is the blastocyst. Now, the decidua which is lying between the uterine cavity and the blastocyst, that is always decidua capsularis. So, over here, this is decidua capsularis, right? And you can see that marked also, right? Now, just opposite to decidua capsularis, what is there? There is decidua basalis. So, just opposite to capsularis, we have decidua basalis. Right? And any other decidua which they mark, any other place which they mark, and they ask you what is it, it has to be decidua parietalis. Clear to all of you how to identify? Now, if that is clear, I have a testing image for you. This image. Now you tell me in this image how you are going to identify. Same thing. First thing foremost, identify the uterine cavity, which will be marked and given to you. This over here is the uterine cavity, right? This over here is the blastocyst. Now, the decidua which will lie between the blastocyst and the uterine cavity, which I am marking with blue X's. So, let me make it green X's so that you can see it. This decidua, this will be your decidua capsularis. So, over here, yes, see, they have marked it here. Decidua capsularis. Just opposite to it will be decidua basalis. So, let us see where our decidua basalis is. Just opposite to here, here should be the decidua basalis. And yes, here we have the decidua basalis. Right? Now, any other decidua which they mark, any other decidua, that should be your decidua parietalis. So, that is your decidua parietalis. Have you understood how to identify decidua on image-based questions? Good. Now, if you've understood that, now what I want you to understand here is, in this image, see just now our blastocyst is small, right? Now, let us grow our blastocyst. So, let's grow the blastocyst. So, this red color blastocyst is growing. So, our blastocyst is growing. Now, you can see that as the blastocyst grows and it becomes an embryo, gradually it is filling the uterine cavity, right? And ultimately, a day is going to come when the embryo is going to completely fill the uterine cavity, right? And the uterine cavity would be obliterated, right? This much understood? Now, the day when uterine cavity would be obliterated, see just now we know that the decidua which lies above the blastocyst, that is decidua capsularis, and the rest of it is decidua parietalis. What I am seeing is that as the blastocyst is growing, what is happening? The decidua capsularis is coming closer and closer to the decidua parietalis. Right? And a day will come when there won't be any distinguishing feature between decidua capsularis and decidua parietalis. Both of them will get fused and you will not be able to identify which one is decidua capsularis and which one is decidua parietalis. Right? So, this question is asked in two ways. Either they can ask you what is the time at which the uterine cavity gets obliterated, Whether they ask you this, then also the answer is 14 to 16 weeks, or they can ask you what is the time when decidua capsularis and decidua parietalis fuse. Then also your answer will be 14 to 16 weeks. A third way of asking this question is, see, in twins, in dizygotic twins, there are two ova which are fertilized by two sperms, right? Now, these two ova, they can be released in the same cycle. If the two ova are being released in the same cycle, so in twin pregnancy, I am telling you that in dizygotic twins, you have two ova which are fertilized by two sperms. Now, these two ova, they can be released in the same cycle, right? If they are released in the same cycle, this process is called as superfecundation. How you are going to remember? S and C, same cycle. Or they can be released in different cycles, right? This is called as superfetation. Superfetation. Superfecundation is seen in humans, but superfetation is not seen in humans, right? But suppose I say that theoretically speaking, suppose superfetation is seen in humans. So till what time is superfetation possible in humans? Superfetation will be possible in humans till the time uterine cavity is not obliterated, right? Once uterine cavity is completely obliterated, sperm cannot enter into the uterine cavity, right? So, same question can be asked in three formats. They can ask you, uterine cavity gets obliterated at what time? Then your answer will be 14 to 16 weeks of pregnancy. When is it that the decidua capsularis and decidua parietalis fuse? Then also your answer will be 14 to 16 weeks of pregnancy. Or they can ask you, theoretically speaking, superfetation is possible up till what time in human? Then also your answer will be 14 to 16 weeks of pregnancy. Is that clear to all of you? Now, if you have understood this much, now you have to understand one more thing. So, on ultrasound, you saw that the first sign was the intradecidual sign. And what was the intradecidual sign? Intradecidual sign was because the blastocyst was going deep inside the endometrium and then implanting, right? So, suppose over here, this is the uterine cavity, right? And over here is our endometrium, right? Now, uterine cavity in case of ultrasound, it appears as a white line, right? So, uterine cavity will appear as a white line, right? And this line will be absolutely straight initially because the blastocyst is going to go deep inside the endometrium and then implant. This is endometrium, right? Now, as this blastocyst is going to grow, now what is going to happen? Now, as the blastocyst grows, it indents on this white line, right? So, now if you draw this image, you can see this image something like this. If this is the uterine cavity, right? And if this is the blastocyst, you will see that as the blastocyst will grow inside the uterine cavity, it will create a bulge in the uterine cavity on ultrasound, right? Now, just now only I told you that the decidua which lies between the uterine cavity and the blastocyst is called as decidua capsularis. So, over here, decidua capsularis will be present. This is your decidua capsularis, right? And I also told you that the rest of the decidua will be decidua parietalis. So over here, this is our decidua parietalis. Right? This is decidua parietalis. So now what I see is that as the blastocyst is growing, this blastocyst is surrounded by two rings. There is an inner ring which is formed by decidua capsularis, right? And there is an outer ring which is formed by decidua parietalis. Right, so this decidua parietalis is forming the outer ring and the inner ring is being formed by decidua capsularis. This is called as the double decidual sac sign or the double decidual ring sign. The double decidual ring sign. Have you understood this? So I told you that initially what happened? Initially, blastocyst went deep inside the endometrium, right? And it went and implanted there, right? Because it went and implanted there, it did not have any effect on uterine cavity. And this is what is called as intradecidual sign. Slowly as the blastocyst grows, whenever the blastocyst will grow, it will come inside the uterine cavity and it is going to indent the uterine cavity complex, which is seen as a line on ultrasound, right? The uterine cavity complex will get indented, right? And this blastocyst will be surrounded by two layers of decidua, right? The inner layer of decidua will be decidua capsularis and the outer layer of decidua will be decidua parietalis. Same thing you can understand in this image which we had drawn here. It's the same thing. Over here, what you are seeing? Over here, this pink color over here is the blastocyst, the growing blastocyst. You can see that this growing blastocyst is surrounded by one ring, the inner ring, right? This inner ring of decidua is decidua capsularis and it is surrounded by an outer ring and this outer ring of decidua is decidua parietalis. Same thing, this is called as the double decidual ring sign or double decidual sac sign. And on ultrasound, how does that appear? On ultrasound, it appears something like this. So this over here is the blastocyst. You can see this blastocyst being surrounded by two rings. The inner ring, if they ask you, this inner ring will be formed by decidua capsularis and the outer ring will be of decidua parietalis. Right? So the first sign on ultrasound in pregnancy is the intradecidual sign and then you get the double decidual sac sign. Clear to all of you, right? Now let's talk a little bit more about the structure which is the blastocyst. Morula was a 16-celled stage zygote. Right? Now, as morula entered into the uterine cavity, not only did water enter into the morula, but morula kept dividing. And a blastocyst eventually has 58 cells. Out of these 58 cells, 5 of these cells are present on one side and they form the inner cell mass. And the rest 53 cells, they form the trophoblast. Now, please don't look at this diagram and say, ma'am, you have drawn more cells here and less cells there. I did not count. Right? I am just telling you facts, but I did not count them while I was drawing this diagram. Right? Now, this inner cell mass, which is present, it is this inner cell mass which is going to form the embryonic disc. And it is this embryonic disc which is going to form the entire embryo. So, the entire embryo will be formed by the inner cell mass. Clear to all of you? Now, let's talk about this green colored cells, which is the trophoblast. So over here, this is trophoblast and this over here is inner cell mass, right? Now this trophoblast on day 8 after fertilization, what happens is that this trophoblast gets divided into two. The trophoblast, the one which retains its cell boundaries, they are the cytotrophoblast. And there will be a layer of trophoblast which will not retain its cell boundaries. It will be like a syncytium, multinucleated syncytium, and that will be syncytiotrophoblast. Right? So day 8 after fertilization, trophoblast divides into cytotrophoblast and syncytiotrophoblast. So this green color is actually cytotrophoblast and this purple color is syncytiotrophoblast. If someone asks you, from where is the syncytiotrophoblast derived? Please remember that it is the cytotrophoblast which gives rise to the syncytiotrophoblast. Right? Next very important questions. Cytotrophoblast is also called as the Langhans cell layer. Langhans cell layer. Right? So these are two very important points which you have to remember over here. So I'm repeating. Day 8 after fertilization, trophoblast gets divided into two layers. The inner layer of the trophoblast will retain its cell boundaries and that will be called as cytotrophoblast. The outer layer is going to it's going to lose its cell boundaries and there will be a syncytium of nuclei which will be present and that is what is called as syncytiotrophoblast. Both of them have got very different functions. Syncytiotrophoblast is the hormone factory of the placenta. It's the hormone factory of the placenta. All the hormones which are formed by the placenta are actually formed by syncytiotrophoblast. And what is the role of cytotrophoblast? This cytotrophoblast divides into two types, right? A villus cytotrophoblast and an extravillus cytotrophoblast. Right? So I am continuing this on the next page that cytotrophoblast gets divided into villus trophoblast and extravillus trophoblast. Now what does villus trophoblast do? As the name suggests, villus trophoblast near decidua basalis, it will form villi-like structures. It will form villi-like structures and this is called as chorion frondosum. I'll just now show you this on the images, right? So near decidua basalis, this cytotrophoblast, the villus cytotrophoblast will form villi-like structure and this area is called as chorion frondosum. And it is this chorion frondosum which gives rise to the fetal side of the placenta. So let's quickly recap. Maternal side of the placenta was being formed by decidua basalis. Fetal side of the placenta is being formed by chorion frondosum. If chorion frondosum is not given in the options, what are you going to mark? Cytotrophoblast. If cytotrophoblast is not given in the options, what are you going to mark? Trophoblast. Right? In that order. Now, that is what happens near the decidua basalis. Rest of the cytotrophoblast, this villus cytotrophoblast, rest of the villus cytotrophoblast remains smooth, right? And it forms chorion levi. Chorion levi. And it is this chorion levi which will form the fetal membrane chorion. So the fetal membrane chorion is also derived from cytotrophoblast. And which part of the cytotrophoblast? Chorion levi. Right? So let me quickly show you a few images here so that you understand. Look at this image over here. Now, in this image, what you are seeing is, this over here is decidua basalis. Can you see decidua basalis? Right? I told you near decidua basalis, cytotrophoblast will form villi-like structure and that is what is called as chorion frondosum. Right? Rest everywhere it will remain smooth and it will be called as chorion levi. Right? And it is this chorion frondosum which will form fetal side of the placenta. Chorion levi is going to form the fetal membrane chorion. Right? Look at this image over here also. Same thing is shown in this image also. In this image also, this over here is Decidua basalis. Near Decidua basalis, you are seeing villi-like structures coming out of the cytotrophoblast, and that is chorion frontosum. Rest everywhere, there is no villi-like structure and it is smooth, and that is called as chorion levi. Clear to all of you now? Cut. Now let's talk about the extravillous trophoblast, the cytotrophoblast. Now this extravillous cytotrophoblast, it has got again two parts, the endovascular cytotrophoblast and the interstitial cytotrophoblast. So I am taking both of them on the other page so that we can write it properly. Now what is the role of this endovascular cytotrophoblast? What this endovascular cytotrophoblast will do, it is going to replace the lining of the maternal spiral arteries. So it will replace the lining of the maternal spiral arteries which open in the intervillous space. So all this you will understand once I do placenta with you, that maternal blood vessels, they open into the intervillous space, and the role of this endovascular cytotrophoblast is to replace the lining of those maternal spiral arteries. And why it is doing so? It is doing so that they get converted from high resistance vessels into low resistance vessels, so that they are converted from high resistance vessels into low resistance vessels. This is happening. You will understand this more clearly when I'm going to talk to you about PIH. Just remember that what is the role of endovascular cytotrophoblast? The role of endovascular cytotrophoblast is to replace the lining of the maternal spiral arteries and to convert them from high resistance vessels into low resistance vessels. And this is called as trophoblastic invasion. This is called as trophoblastic invasion, and this trophoblastic invasion, it occurs in two steps. The first wave of trophoblastic invasion is completed by 12 weeks of pregnancy, and the second wave is completed by 16 weeks of pregnancy. As of now, if you are not understanding what has happened, it's okay. You will understand this when I will teach you more about PIH, and when I will talk to you about placenta, you will understand this more. As of now, you should write it so that it is there with you whenever you want to refer to it, right? Now, what is the role of interstitial cytotrophoblast? Again, you might not understand it. Okay. Start. What is the role of interstitial cytotrophoblast? Again, you might not be able to understand it here just now, but when I talk to you about placenta, you will understand that. As of now, just write that interstitial cytotrophoblast, it forms the cytotrophablastic shell. What it is and where it is, you will understand when we do placenta, right? So this was the role of cytotrophoblast. Cytotrophoblast is the one which is basically responsible for formation of fetal site of the placenta. It is the one which is responsible for forming chorion, and it is the one which helps in keeping the resistance in the mother's blood vessels less. Right? So it brings down the resistance of the mother's blood vessel. If this trophoblastic invasion does not happen, then this can lead to uteroplacental insufficiency, this can lead to PIH, this can lead to IUGR. So this step is very, very important, right? And how and why it is important, you'll understand later, right? What was the role of syncytiotrophoblast? The role of syncytiotrophoblast was that it is the hormone factory of the placenta. Apart from this, cytotrophoblast and syncytiotrophoblast don't have any role. The only thing is that it is the entire embryo is formed by the inner cell mass. So it's the inner cell mass which has got a very, very important role of forming the entire embryo. So let us focus now on the inner cell mass, right? Now, inner cell mass, So this over here, the 5 cells over here are the inner cell mass. Now this inner cell mass, it is going to form an embryonic disc. Right? So it is going to form an embryonic disc. Right? Now this embryonic disc is going to divide the entire blastocyst into 2 cavities. The cavity which is formed above the embryonic disc, that is amniotic cavity, and the one which is below that is the yolk sac. This amniotic cavity is lined by endoderm. So over here, ectoderm. So over here we have the ectoderm, right? So if I ask you which is the first germ layer to be formed, it is ectoderm. This ectoderm is going to give rise to amnion, right? So amniotic cavity, on one side it will be lined by ectoderm and on the other side you have the amnion. And from where are you getting the amnion? You are getting amnion from ectoderm. From where were you getting chorion? Chorion you were getting from cytotrophoblast, right? Now, yolk sac is lined by endoderm. This endoderm. The second germ layer to appear is the endoderm, right? Now, because yolk sac is surrounded by endoderm, yolk sac is also called as the endodermal sinus. So when we are going to do ovarian tumors, one of the variety of ovarian tumors is a yolk sac tumor. The other name for the yolk sac tumor will be endodermal sinus tumor, because the other name for yolk sac is endodermal sinus, right? Now, so the first germ layer to be formed is ectoderm. The second germ layer to be formed is endoderm. And then from the primitive streak, we will have the third germ layer coming in, and that third germ layer will be your mesoderm. Right? In between them will come mesoderm. So the last one to appear is mesoderm. Right? So write down mesoderm. Next question is amnion is formed by? Amnion is formed by ectoderm. Right? Have you understood till here? Now another name for yolk sac, just now I told you, it is endodermal sinus. Now because of the appearance of yolk sac, on ultrasound, now you are going to get 2 cavities, right? So one cavity is this amniotic cavity and the other cavity is yolk sac. And this is called as a double bleb sign on ultrasound, right? So because of the appearance of yolk sac on ultrasound, we are going to get a double bleb sign. Right? Double bleb sign means now you can see 2 cavities. The above cavity, the one which is lined by ectoderm, is amniotic cavity, and the one which is lined by endoderm is the yolk sac. And this is how an embryonic disc is formed. This is the embryonic disc, and it is this embryonic disc which is going to give rise to the entire part of the embryo. Right? Now this embryonic disc, if we curve the embryonic disc, right? So I'm curving the proximal end and I'm curving the discordal end of the embryonic disc. So over here we have a cranial fold and we have a caudal fold, and now you can see it's resembling a little bit the embryo, right? So the entire embryo has to be formed from the embryonic disc, and I am curving the caudal end and the cranial end of that embryonic disc. So I am getting a cranial fold and I am getting a caudal fold. Now these are seen, these caudal folds and cranial folds, they are seen as embryonic poles on ultrasound. So fetal poles on ultrasound are actually nothing but the foldings of the embryonic disc, right? Now, when we say that we have to measure the crown rump length. So what is crown rump length? If you remember from your undergraduate time, crown rump length is the distance between the vertex and the buttocks, right? The coccyx. So, or you can say that crown rump length is the distance between the cranial fold and the caudal fold, right? So, the distance between cranial fold and caudal fold is the crown rump length. Clear to all of you till here? Okay. So, now the embryo has started appearing. We are getting a shape similar to the embryo, and now all the 3 germ layers are formed. Now what happens in this embryo? A caudal fold has been formed and a cranial fold has been formed. Now heart starts beating in this embryo, right? And on what day does the heart start beating in the embryo? Heart starts beating in the embryo on day 21. After fertilization. Day 21 after fertilization. Right? Clear to all of you? Now, if you do an ultrasound in early pregnancy, what are the structures which you are going to see? When you do an ultrasound in early pregnancy, see, I'm not talking about the signs which you are seeing. I am talking about the fetal structures which you are seeing. Till now, we were talking about the fetal signs, the signs which you see on pregnancy on ultrasound. And the signs which you were seeing were, number 1, intradecidual sign. Number 2, a double decidual sac sign. And just now we saw a third sign, and that was a double bleb sign. Now I am talking about what are the fetal structures which you see on ultrasound. The first fetal structure which you see on ultrasound is the gestational sac, right? And at what time do you see gestational sac on transvaginal sonography? Gestational sac is visible on 4 weeks 1 day to 4 weeks plus 3 days, right? So 4 weeks plus 1 day to 4 weeks plus 3 days, this is the time of pregnancy, right? That when you are seeing the gestational sac. Clear to all of you? This is you see gestational sac on TVS. If I ask you on trans-abdominal scan, when do you see a gestational sac? So whatever structures are visible on transvaginal scan at whatever time, you have to add 1 more week to it to see it on trans-abdominal scan. In pregnancy, generally we use a transvaginal scan in early pregnancy, right? So on TVS, you will see a gestational sac from 4 weeks plus 1 day of pregnancy to 4 weeks plus 3 days of pregnancy. Then the second thing which you are going to see is a yolk sac. Yolk sac will be seen at 4 weeks plus 5 days of pregnancy, or approximately you can say we will see in 5th week of pregnancy. And then you will have the crown rump length. And then fetal cardiac activity would be visible. Here the cardiac activity is visible, right, on ultrasound. I am not saying that you can hear fetal heart sounds. Fetal heart sounds cannot be heard at this time. Here just now you are seeing the fetal cardiac activity on ultrasound, right? And when can you see fetal cardiac activity on TVS? Fetal cardiac activity can be seen on TVS between 5 to 6 weeks. But if I ask you on trans-abdominal scan, when can you see fetal cardiac activity? You have to add 1 week and you are going to say that it is seen between 6 to 7 weeks. Now suppose your question is, fetal cardiac activity can be seen on ultrasound at, and they haven't mentioned that whether they are talking about TVS or about TAS, then fetal cardiac activity can be seen on ultrasound at, you are going to mark it as 6 weeks. Clear to all of you? Question, if it comes to you that heart beats for the first time in the fetus, they are going to say day 21 after fertilization. Cardiac activity can be seen on ultrasound at 6 weeks of pregnancy, right? This is 6 weeks of pregnancy. Right? Now, there is a lot of difference between 6 weeks of pregnancy and if you are saying something from the day of fertilization. What is that difference? See, understand this. This is the first day of a female's menstrual cycle, and I told you in pregnancy, always we assume that her cycle is of 28 days. right? And we assume that on day 14 she ovulated and on day 14 fertilization happened. Now, if fertilization happened on day 14, then on day 28, when she was about to have a period, she will not have because now she's pregnant, and this will become her missed period. Right? Are you understanding this? Okay. Now, this is her missed period. This means that from now on till 9 months, she will not have any period. So, this means that this first day becomes her first day of the last menstrual period. And this is the place from where pregnancy is calculated. Pregnancy is calculated from here. Pregnancy is never calculated from the day of fertilization. So, when I say 4 weeks plus 1 day of pregnancy, so that means I'm counting those 4 weeks from here. Which also means that if suppose there is a female who has become pregnant and she did her urine pregnancy test on the very day when she had a missed period, right? And her urine pregnancy test comes out to be positive. Right? So, if she comes to me and she says, the doctor, I missed my period today, I did a UPT and my urine pregnancy test has come out to be positive. Tell me how many weeks pregnant I am. You are going to tell her that she is 4 weeks pregnant because pregnancy is calculated from the first day of the last menstrual period. Although fertilization happened just 2 weeks back. But the pregnancy will be called as 4 weeks of pregnancy. Are you understanding this? Because this is a very, very important concept, bachcho. If you haven't understood, you will not be able to explain it to your patient. Right? And why would you need to explain it to your patient? Suppose a hypothetical situation. The hypothetical situation is that there is a female who got married on the 1st of January. Right? And she had a 28-day cycle. On 28th of January, she was expecting her period. And this female, she got married on the 10th of January. Right? Now, on 14th of January, she ovulated and she conceived. On 28th January, she was about to have her period, but she did not have. Right? So, she waited for 1 or 2 days. And since she did not have a period, she got a urine pregnancy test done. And the entire family that, oh, the newlywed female has got pregnant, the husband, the mother-in-law, all of them come to you with the report, with the test that she has become pregnant, right? And you tell her that she is 4 weeks pregnant, right? Now that can create a lot of controversy. So you will have to understand this, that this female conceived just 2 weeks back, but we calculate pregnancy from the first day of the last menstrual period. Clear to all of you? So when I say that a gestational sac is visible on 4 weeks plus 1 day, right? So 4 weeks plus 1 day means it is visible on the 29th day, which means that if I ask you that earliest gestational sac can be seen on ultrasound after how many days of fertilization? So after how many days of fertilization? From 14 to 29 is 15 days. So 15 days after fertilization. Are you understanding this concept? It is 4 weeks plus 1 day of pregnancy, right? And pregnancy is calculated from the first day of the last menstrual period. Same question if they ask you is after how many days of fertilization? Then that means from day 14 you have to go till 4 weeks plus 1 day of pregnancy. 4 weeks plus 1 day of pregnancy means 29th day. Right? So 29 minus 14, that is day 15 after fertilization. I hope this much maths you will be able to do and you will be able to understand. Just in case you haven't understood this concept, please pause the video right now and go back, listen to it again and then go ahead. Right? So all events in pregnancy are always calculated from the first day of the last menstrual period. And this concept I'm going to repeat again when I'm going to talk about basics of pregnancy. Right? It's a very, very important concept. Clear to all of you? Okay. Now, so we got lost a little bit from the track. I'm coming back to the track. The track was that what is the first fetal structure which is seen on TVS? The first fetal structure which is seen on TVS is gestational sac, right? Then you get a yolk sac. Then you can measure the crown rump length, and then comes cardiac activity. You do not have to confuse it with the signs of pregnancy. If they ask you what is the first sign of pregnancy on ultrasound, the first sign of pregnancy on ultrasound is the intradecidual sign. Intradecidual sign corresponds to the formation of gestational sac. When a gestational sac will be formed, then intradecidual sign will become positive, right? The second sign will be a double decidual sac sign, and then there will be a double bleb sign. Double bleb sign means that a yolk sac has now formed. Clear to all of you? Okay. Now, if they ask you what is the first fetal structure seen on ultrasound, you know the answer that the first fetal structure seen on ultrasound is gestational sac. Am I clear? Okay. Now, if this much is clear to you, now comes a very important next concept. The next concept is that in all intrauterine pregnancies, gestational sac should 100% be visible on ultrasound if the value of beta HCG is above 2000 international units per liter. I'm repeating this sentence for you. In all intrauterine pregnancies, in 100% cases, the gestational sac should be visible on ultrasound. And which ultrasound? On TVS. If the levels of beta HCG are more than 2000 international units per liter, right? Now, why is this fact so very important? This is important because this is going to help you in distinguishing between ectopic pregnancy and a normal intrauterine pregnancy, right? So, suppose you get a question which says, Case 1, that there is a female in whom the beta HCG value is more than 2000 international units, but no gestational sac is seen on TVS. What is it? Now, if I am telling you that if it is a case of intrauterine pregnancy and if the levels of HCG are more than 2000 international units, then 100% on TVS you should be able to see a gestational sac. If levels are more than 2000 and you are not seeing a gestational sac on TVS, that means implantation has not happened in the uterus and implantation has happened elsewhere, which means it is a case of ectopic pregnancy. Have you understood this here? So this value of beta HCG 2000 is very important. This value of HCG is called as the discriminatory zone. What is it called as? The discriminatory zone, or it is called as the critical value of beta HCG. So critical value of beta HCG is defined as that value of HCG. That value of HCG beyond which in intrauterine pregnancy, in 100% cases, gestational sac should be visible, right? And this value of beta HCG in case of TVS is 2000 international units, and in case of TAS, trans-abdominal scan, is 6500 international units, which means that if beta HCG is more than 2000 and on TVS, you should be able to see gestational sac in intrauterine pregnancy. And if the levels of beta HCG are more than 6500 international units, then on TAS, in intrauterine pregnancy, 100% you should be able to see gestational sac. Have I made my point clear? Okay. Now, if this point is clear to you, please, bacho, there are a few lectures which I am retaining from edition 4. And one of the lecture which I am retaining from edition 4 of Marrow is ectopic pregnancy. Now, In ectopic pregnancy lecture, you will see that I am telling you that the critical value of beta HCG on TVS is 1500 international units. So please do not get misled and do not write to me that ma'am, in ectopic pregnancy chapter you have said that beta HCG value is a discriminatory zone of beta HCG for TVS is 1500 and here you have said 2000. This is the new lecture which has been recorded and this is the new and the updated value which I am telling you. I will add a correction note there in ectopic pregnancy. So remember that ectopic pregnancy is being retained from edition 4 and there the value of beta HCG which I have said verbally is 1500 but that is incorrect. That has now been changed and now it is 2000 international units. Right? So what I am telling you here is the updated value. Right? Okay. Now let's talk about another case. The other case is, suppose there is a female in whom on ultrasound we did not see any gestational sac. Her urine pregnancy test is positive. So there is a female whose urine pregnancy test is positive. I did not see any gestational sac on TVS. Now when I did not see any gestational sac on TVS, I got her HCG levels done and I saw that her HCG levels are less than 2000. Now what should I do? If the levels of HCG are less than 2000, I have to wait, right? One thing what I can do is I can tell her to wait and come to me after 1 week, right? And I will repeat her ultrasound after 1 week. The other thing what I can do is I can repeat her beta HCG after 48 hours, right? So these are the two things which I can do. Normally what happens is, normally in an intrauterine pregnancy, the levels of beta HCG double after every 48 hours, right? So I can tell her to get a beta HCG repeated after 48 hours. After 48 hours, if her beta HCG levels double, right? If her beta HCG levels double, then I know that I am dealing with intrauterine pregnancy. But if her beta HCG levels increase and they do not double, so they are increasing but they do not double, then it means it is a case of ectopic pregnancy. And this question was asked in AIIMS, that there is a female whose UPT is positive and her beta HCG levels are less than 2000, gestational sac is not visible. What is the next step? And in the options you were given, repeat beta HCG after 48 hours. So this is what you will do. Either you will repeat beta HCG after 48 hours or you will wait for 1 week and repeat ultrasound. Right? Because if beta HCG is less than 2000, I cannot say whether it is a case of ectopic pregnancy or whether it is a case of intrauterine pregnancy. Have you understood? Okay. Next very important point. Next important point is if the gestational sac is more than equal to 10 millimeters. Now, when I say gestational sac is more than equal to 10 millimeters, the term which can be used in your questions is mean sac diameter, MSD. Mean sac diameter. What do you understand by mean sac diameter? Mean sac diameter means if this is the gestational sac, you are measuring the length, the breadth and the width and you are dividing it by 3 and whatever value you get is the mean sac diameter. So whether I say gestational sac is more than equal to 10 millimeters or I use a specific term, mean sac diameter is more than equal to 10 millimeters. Right? So suppose your question is saying that mean sac diameter or the gestational sac is more than 10 millimeters and no yolk sac is seen. Right? So you know the sequence. You know that first what should be seen? First a gestational sac should be seen and then a yolk sac should be seen. Now the question is saying that gestational sac is more than equal to 10 millimeters but still a yolk sac is not seen. Now, what is your diagnosis? Please remember that if gestational sac is more than 10 millimeters and still a yolk sac is not seen, it means that this gestational sac is a pseudo-gestational sac of ectopic pregnancy. It is not a true gestational sac. So we come to a very, very important thing, and that is a pseudo-gestational sac and true gestational sac. Now, pseudo-gestational sac. Pseudo-gestational sac is seen in case of ectopic pregnancy. True gestational sac is seen in case of intrauterine pregnancy. Now, I told you what is a pseudo-gestational sac. Pseudo-gestational sac is actually the thick decidua. It is the thick decidua which appears like gestational sac. Right? So, pseudo-gestational sac is nothing but the thick decidua which is appearing like a gestational sac. Now, in case of ectopic pregnancy or a pseudo-gestational sac, the pseudo-gestational sac is always located centrally. Whereas, just now I told you sometimes back that a true gestational sac is always eccentric in location. Right? A pseudo-gestational sac, its size remains constant. It will not grow. Whereas a true gestational sac will grow by 1 to 2 millimeters per day. Right? A pseudo-gestational sac, it will never show the double decidual sac sign, because implantation is not happening in the uterus. So if implantation is not happening in the uterus, obviously there won't be any decidua capsularis, any decidua parietalis, any decidua basalis. The entire endometrium will be called as decidua, but there won't be any subdivision. And if there won't be any subdivision, there won't be any double decidual sac sign. Whereas in case of true gestational sac, double decidual sac sign is present. Clear to all of you? Yes. So, next, in case of pseudo-gestational sac, you will never get yolk sac. Whereas in a true gestational sac, you will get yolk sac. Yolk sac will be present. Now, because in a pseudo-gestational sac, you will never get a yolk sac, that is why you will never get double bleb sign. Whereas in case of true gestational sac, because yolk sac will be present, so double bleb sign will be seen. Right? So that is how you distinguish between a true gestational sac and a pseudo-gestational sac. Remember, a pseudo-gestational sac is nothing but thick decidua in ectopic pregnancy. Right? Whereas a true gestational sac will be seen only in intrauterine pregnancy. So if you are seeing a gestational sac which is as big as 10 millimeters, and you are not getting any yolk sac, so you know that yolk sac is not seen in case of pseudo-gestational sac, and that means you are looking at a pseudo-gestational sac of ectopic pregnancy. Clear to all of you? Okay. Now comes our next concept. The next concept is, if the mean sac diameter is more than 25 millimeters and yolk sac is present, so the gestational sac is present, yolk sac is present, the size of the gestational sac is more than equal to 35 millimeters, but you are not getting any fetal tissue, you are not getting any crown rump length, right? And obviously, if you are not getting any crown rump length, you are not getting any cardiac activity, because crown rump length appears first and then cardiac activity. So if mean sac diameter is more than 25 millimeters and still you haven't got any fetal poles, you haven't got any crown rump length, and you haven't got any cardiac activity, what does that indicate? That indicates that you are dealing with blighted ovum. It is a type of abortion. A type of abortion where no fetal tissue is recognized. Right? So you are dealing with a special type of abortion where no fetal tissue appeared, just the gestational sac and yolk sac had appeared. Right? And this is called as an embryonic pregnancy or blighted ovum. right? So in order to diagnose blighted ovum or an embryonic pregnancy, the size of the gestational sac should be more than equal to 25 millimeters. Clear to all of you? Now, the last case is, suppose gestational sac is also present, yolk sac is present, crown rump length is present. Right? Now, after crown rump length, what has to come? Cardiac activity. Now, suppose crown rump length is present and it is more than 7 millimeters. Right? But you haven't got any cardiac activity. So, if crown rump length is more than equal to 7 millimeters and you haven't got any cardiac activity, that indicates missed abortion. Have you understood? Mean sac diameter more than 25 millimeters. Yolk sac present but no fetal tissue seen, no fetal pole seen, no crown rump length seen, no cardiac activity seen. That is blighted ovum. Now, yes, gestational sac is present, yolk sac is present, crown rump length is present, but cardiac activity did not come. And till when did you wait? You waited till crown rump length was more than equal to 7 millimeters. So, if crown rump length is more than equal to 7 millimeters and still you are not getting any cardiac activity, you declare it as a case of missed abortion. In case of missed abortion, please remember that patient will not have any bleeding. Right? So, patient is not going to come to you that I am having bleeding. If patient is coming to you with bleeding, then you know it's abortion. Right? Here, patient won't have any symptoms. The only thing what will be seen is that on ultrasound, you are not getting any cardiac activity. Right? So, let us do one or two case scenarios before I conclude this topic. So, case 3. There is a female whose urine pregnancy test is positive. An ultrasound was done. A gestational sac was present and what was the mean sac diameter? 20 millimeters. Yolk sac was present, but there is no crown rump length and no cardiac activity. Right? Now, I told you that you have to wait until 25 millimeters before you declare it as a blighted ovum. Here, the mean sac diameter is 20 millimeters. Just now it is not 25. So I am not going to be in a hurry to say it is a case of blighted ovum. No. I am going to wait and watch. Right? Maybe, in this case, cardiac activity or the fetal tissue is coming a little late. Right? So I am going to wait till 25 millimeters. Is that clear to you? Okay. Case 4. If it is the same question, but they are saying that the gestational sac is 27 millimeters. Right? So, yolk sac is present. Gestational sac is 27 millimeters. There is no crown rump length and there is no cardiac activity. So, I told you that you have to wait maximum up till 25 millimeters. Right? Here it is 27 millimeters. Now, I am going to tell the patient that you have a blighted ovum. Now my diagnosis is blighted ovum. Clear? So all these facts which I have told you are very, very important from clinical Winnett's point of view. See, as far as the new pattern is concerned, the next exam is concerned about which all of you are so worried about. Don't worry. If your concepts are clear, if your basics are clear, you can answer any question. Right? And these are the concepts which you have to remember for solving clinical questions. So, keep revising in the meantime. Copy each and every line which I have told you in the notes and I'll see you in the next lecture. Take care.